Today I decided actually to explain these pictures and the patient and the case instead of putting a music on. So this is a 65-year-old female with a long history of back pain and radiculopathy. Most of the symptoms though correspond to the lower lumbar spine, L2 to S1. And as you see, we are dealing with grade 2 spondylolisthesis, quite significant disc disease, and scoliosis. And patient's axial back pain has been treated for years, which has not responded favorably. And practically, we are going to discuss the surgery after conservative therapy has failed. As you see, patient has in this myelogram significant disc disease and stenosis in lower lumbar spine, mostly foraminal and lateral recessive stenosis. Patient as well has a thoracolumbar disease and scoliosis, but clinically that is less pronounced, and patient mostly suffering from lower axial back pain and radiculopathy corresponding to L3, 4, 5, and some S1. Patient has known osteoporosis, and that will become more important during the surgery. We decided to do a minimal invasive approach with OLLIF technique, and I'm going to share now the surgical pictures of this patient. And practically we are going to look at, first of all, the quality of the pictures are very poor, not because patient has obesity. As a matter of fact, BMI was within reasonable number, but the patient has osteoporosis, so bone differentiation is somewhat difficult. And we spent way more than usual in the AP and lateral pictures for the imaging. The APs are more visible. As you see, patient has a torsion and significant disc disease here and here. And in the lateral view, though, we had quite significant difficulty to visualize the anatomy. Though, if you look carefully, you see the pedicle here, disc here, foramen here, and to get a better picture, as you see, you have the double shadow. I'm trying to find out what is the amount of the torsion is there, and I'm going to just go through significant number of pictures to evaluate that. And here you see that the double shadow is almost gone. Now I'm looking at the other levels to see the proper positioning of the C-arm. With the double C-arm technique, the setting is extremely important, that when you are moving these C-arms, they are not in each other's way and doesn't prevent the good imaging. Here you see that practically even if you concentrate on one disc, the other disc and pedicles are out of focus. And here practically after for 10 minutes or so working on the proper imaging, we see that, finally I decide that for 5S1, this is the proper kind of imaging that would give me access to 5S1. At this time, time is 10:42, so I'm going to advance this picture. As you see, I spent almost 20 minutes to familiarize myself with the proper kind of setting that would get us there. And here we are at the 11:42 here. This C-arm has still the winter time, so they're just offset by 1 hour. So here we start the process by getting first a Jamshidi in the pedicle of the 5. This is the first thing we do. We get some bone marrow and soak our tricalcium phosphate with it. We have noticed that by doing that, our fusion rate is significantly higher by soaking the tricalcium phosphate not with blood but with bone marrow, at least 2 to 5 minutes. So here the bone marrow is received, and then we go in with the neuromonitoring probe, and here in both AP and lateral view. The approach was very difficult because there's significant osteophytic changes, facet growth, and a few times we got an approach, but we did not have a good neurophysiologically silent area in the kambin triangle. Here we finally get into the disc and dilate, and the tube is placed. We have noticed that the tube has to pass at least half of the pedicle, and once the tube is in place, we use as you see here, I notice at this point when the tube is in place, we have almost passed half of the vertebral body. And here the same. So we are almost half pass of the pedicle, half of the pedicle, but significantly advancing the AP view, in the lateral view. So that would not give us enough space to work with. So for that reason, I decide that this approach is not adequate, and decide to get a better approach, to medialize the approach a little more. As you see here, this is the second approach, to medialize the approach. And here you see that the K-wire passed to the anterior border of the vertebral body and has passed the midline. So we are trying now to get this approach. Because of the soft bone, it seems that we still have some difficulty to get the proper approach. But now finally we are able to do discectomy, use a ring probe and pituitary, and then finally put the cage in. Cage is not exactly in the midline, but all our study shows that plays no role whatsoever. Fusion still can be achieved very adequately, and trying sometimes to get at the very midline position will cause that you slip and cause more damage than good. As we say, the enemy of the good is trying to do better. Now I put the K-wire on the other side, and then I put in this setting where we have the pedicle of the S1 visualized, I put as well the K-wires in the S1 as well. So we are done with the lower segment, which is as well the most difficult. And now we are going to move, here you see I'm adjusting to get a good view to put the K-wires for the S1. Now we are going to adjust it for 4-5. And here finally we see the pedicle of the 4. Disc is visualized, and at this point I put the first K-wire. After here you see I'm working on the discectomy of the 4-5, and the cage is placed. Now the K-wire is placed in the L4. Then we again reposition and readjust the pictures for, and here you see that I'm rotating to get a better picture and identify the trajectories, and we enter the disc base, perform a discectomy, and prepare the end place, and the cage is placed. Again, here if you pay attention, you almost don't see the disc of the 2-3, but now that I'm changing the angle, and again I have to work hard to visualize it, and here you see that finally we are getting the pictures visualized for the 2-3. We are almost 1 hour through the surgery, and here we move on again to the position that we are going to enter the disc of the 3-4, the worst disc disease for this patient. And again, as usual, we perform a discectomy, prepare the end plates, and the cage is placed. Now we are going to put the K-wires in 2 and L3. And here we are moving forward with putting the K-wires. We get about 5 cc of bone marrow from each level. Our study showed that by removing more than 5 cc, we are mostly getting blood and not bone marrow and very little stem cells. Bone is soft. You see I'm struggling a little to get into the pedicle now, but here at this angle, we are able finally to get it in. And here you see that on the other side. At the end, we got really good response with neuromonitoring. One of the things we do, we put the Jamshidi in and stimulate the Jamshidi, because it's much easier to reposition at this time than after we put the screw in. Here's the almost final in the AP, but now in the lateral, you see I'm using the corticator for facets of the levels that this 2, 3, 3, 4, 4, 5, 5 S1. Obviously, we don't use this for decortication because that would be the facet of L1, 2. Now, after we decorticate, put tricalcium phosphate soaked with bone marrow and tap it into holes of the facet that we open with the decorticator, we put the screws in. And here are the screws that going in. Because of the quality of the pictures are so poor, I decided to get a post-op CT that you will, I will look at it with you. Here you see the bone is so soft that when I'm trying to reduce this, actually instead of reducing the rod, it pulled the screw out. Now at this point I can take the screw out, put a bigger screw in and redo that, but I decide rather than save the situation by putting screws in all others and very slowly reduce them. And in a way, I should have done it from the start. And now we are reducing and the same screw advances again and bone will grow around it. It'll be all right. I just saved us half an hour time by not trying to take the rod out. Now here is the final views, and now for this patient I got a post-op CT because I was very concerned about the quality of the picture and if we got all the screws in the right place. Even with this poor quality picture, the result has been very good. So here we are with the L2 screws. As you see, I used very big screws. Screws are almost same size as the pedicle, but they are dead centered. The double C-arm technique really let you do that. And then the screws, cage is good. The L3 screws are as well dead centered. L4 screws, L5 screws, and S1 screws, they are all well positioned. Screws in the lower area, I usually try to get them bicortical. As you see, they are extruding through the bone, which is very safe as long as you stay within a centimeter from the bone. And so we see here that in the area of the surgery, surgery has been very successful. All the hardware are in excellent position. And here, as you see, that even with this difficulty of the bone density and poor pictures, all the hardware are excellent position. These are post-operative x-rays that again show hardware in excellent position, and I don't see any sign of difficulty in the hardware. And most of this, overall, it seems that the spine is straight up and down. This is the data regarding the surgery that we performed just a few days ago. By the way, patient was discharged just 2 days after the surgery. All the screws are inside these boxes mentioned. Our surgery time was extraordinarily long for a 4-level fusion. Usually our 4-level fusions are done within 1.5 hours to 1 hour and 40 minutes. Here, the surgical time, OR time, was 131, meaning 2 hours and 11 minutes, which is half an hour longer. But considering that a 4-hour surgery, that 4-level fusion for scoliosis can be easily a 8-9 hour surgery, this is still pretty good. Our blood loss as well was a little more than usual, 282. That is because we had to spend more time in the OR. Patient did very well, was discharged within 2 days, and overall I was very happy with the end result. Now, one of the characteristics was that the patient's leg pain was gone right after the surgery, and patient did ambulate the same day of the surgery. So overall, we were very happy with the result of this surgery. Please send me any comments or question you have, and I will answer it.